Hi everyone and welcome to our module on mood disorders. Mood disorders are psychiatric conditions in which patients have an abnormal emotional state. And if you think about your emotional state, on a normal day it probably fluctuates between times when you might feel mildly sad or times where you might be happy. The same is true in mood disorders, except the emotional states are extreme. So patients who have extreme sadness are said to have depression, and they're at one end of the mood disorder emotional scale. Patients who have extreme happiness and high levels of energy and activity, those patients are said to have mania, and they're at the other end of the scale. So most people think about mood disorders as occurring along this spectrum. Let's start by talking about major depressive disorder, which most people just call depression. Patients with this condition have a chronically depressed mood. They have a loss of interest in activities like going out with friends. This is called anhedonia. They're often fatigued with a loss of energy, and when you're in primary care and a patient presents with fatigue or tiredness, one of the things you have to consider is that they might have depression. They often feel worthless or guilty about many things in their lives. They can develop suicidal ideation and sometimes attempt suicide. We'll talk more about that later. They often have trouble concentrating and making decisions, and this is another classic symptom of depression and something you have to consider when someone is struggling at work or school. There are also a couple of disturbances which people often don't associate with psychiatric conditions, but they classically occur in depression. The first one is appetite changes. So some patients will lose their appetite when they're depressed. Other patients will eat more than usual. And for this reason, patients sometimes gain or lose weight. In addition, many patients have sleep disturbances. Some patients have trouble sleeping, other patients sleep a lot. And so all three of these, even though they are physical complaints, are also complaints of depression. And then finally, one of the other features of depression, which we'll talk more about in a minute, is called psychomotor agitation or retardation. So let's drill down in a little more detail on some of the features of major depressive disorder, and let's start with the sleep disturbances. Patients with depression can have many forms of insomnia. Some of them have difficulty getting to sleep. This is called initial insomnia. Other patients wake during the night frequently. This is called middle insomnia. And some patients wake earlier than usual and can't get back to sleep. This is called terminal insomnia. And all of these can occur among patients with depression. At the other end of the spectrum, there are some patients with depression who have hypersomnia. They don't have trouble falling asleep. They have excessive sleeping. And then finally, it's high yield to know for step one of your boards that patients with depression have altered sleep rhythms. In the video on sleep disorder, I talk in detail about normal sleep rhythms. Patients with depression have abnormalities involving a number of portions of sleep rhythms. First of all, patients who have depression have REM sleep that starts quicker after sleep onset. This will be described in your textbooks as a decrease in REM latency, meaning a decrease in the time until REM occurs. Normally, you have a number of phases of non-REM sleep before REM sleep begins. In patients with major depressive disorder, the REM sleep begins faster. In addition, these patients have an increase in their total REM sleep, and they have a decrease in their slow wave sleep. And then finally, when these patients take antidepressant drugs and are treated for their depression, the sleep rhythms normalize. Earlier I mentioned psychomotor agitation and retardation, so let's talk about what those terms mean now. Psychomotor agitation means excessive motor activity. It's often repetitious. Patients complain of a feeling of inner tension. They sometimes will fidget or pace, and these are seen among patients who are depressed. Some patients are at the opposite end of the spectrum. They have psychomotor retardation, so when these patients are depressed, they have a slowing of their movements, thinking or speech. They're slow to answer questions. They can appear lethargic when you talk to them. They speak in a low, quiet voice and don't say many words. This is psychomotor retardation, and both of these are seen among patients with depression. To diagnose major depressive disorder according to the DSM-5, a patient has to have 5 symptoms out of 9 for at least 2 weeks. And the 9 potential symptoms are usually remembered by the mnemonic SIG-E CAPS. The 9 symptoms are all these things shown right here in this slide. These are all things we've been talking about for the last few minutes. In addition, there can be no evidence of mania. If a patient has evidence of mania, either at diagnosis of depression or in the past, then they have bipolar disorder, not depressive disorder. We'll talk more about that in a minute. And the treatment is with antidepressant drugs, which I talk about in another video. Psychiatrists sometimes break down patients with major depressive disorder into a number of subtypes. I've listed the major subtypes on the screen here. I don't recommend you learn a lot about all of them, but the one that you should know for step 1 is atypical. That's because this is the most common subtype in some studies, and it has a couple of unique features. The atypical subtype of depression has mood reactivity as its core unique feature. Mood reactivity means that even though the patient is depressed, they are still able to react to some pleasurable stimuli, and they feel better sometimes when good things happen. This is called mood reactivity, and this is what's seen in atypical depression. Other features of atypical depression are shown in this slide. These patients tend to eat and sleep a lot, so they have an increased appetite and they often gain weight. They also tend to be sleeping all the time. That's hypersomnia. A common complaint is heavy or leaden feelings of the limbs, and these patients tend to be very sensitive to rejection. They often have a history of interpersonal rejection sensitivity. So, for example, if a friend said they were upset with something they did, they take this particularly hard, that sensitivity to rejection, and that's seen in atypical depression. As I said before, this is the most common subtype in some studies, and there were some older drug trials that showed an increased response to the MAO inhibitor antidepressant drugs. It turns out, however, that SSRIs are also effective, and SSRIs are a standard antidepressive therapy. So in the modern era, most patients with atypical depression are treated with SSRIs because they have far fewer side effects compared to the MAO inhibitors. But nevertheless, I mention this because you'll see in some of your textbooks that atypical depression responds to MAO inhibitor drugs. Now let's move ahead and talk about mania. Mania is like the opposite of depression. Patients with mania have an abnormally elevated mood and they have an abnormally high energy level. Mania tends to occur episodically, and when it comes on, we say that the patient is having a manic episode. During a manic episode, some of the things you can see are that the patient may talk fast and have pressured speech. They often don't need to sleep, although they're not tired. This is different from insomnia. These patients just can stay up for days at a time. I met a woman once who didn't sleep for 10 days during a manic episode. They have psychomotor agitation, not retardation. You don't see psychomotor retardation in mania, so they will be pacing and fidgeting during a manic episode. And then they often have flight of ideas, so they keep moving from one thing to the next that they are thinking about or talking about. It's hard for them to stay on a single topic or task. Other features of a manic episode are shown on this slide. Disinhibition, especially with irresponsibility, is a classic feature of a manic episode. Patients will often waste money. Some patients have been known to spend their entire bank account on wild purchases. Sometimes patients are known to go outside wearing no clothes. Grandiosity is another classic feature. These patients will have increased self-esteem and confidence and feel like they can do anything that they want. So a typical case of a manic episode is a patient who suddenly changes his or her mood to an elevated state. They don't sleep for several days, they have altered behavior, and this tends to disrupt their social functioning. Many patients won't go to work and will be engaging in wild activities for several days until the manic episode passes. The diagnosis of a manic episode requires symptoms that last for at least a week for most of the day, and the symptoms of a manic episode are shown on this slide. These are all the things we've been talking about. Most people remember them by the diagnosis dig fast. So the picture you should have in your mind of a manic episode is a patient who suddenly doesn't want to sleep, is full of energy, is running from task to task, talking wildly, often engaging in disinhibited or irresponsible behavior. That patient is having a manic episode. A hypomanic episode is similar to a manic episode, but it is less severe, and one of the key features is that there is little to no impairment in functioning. So patients during a manic episode may not go to work because they are manic and they are running around from place to place, spending money, doing wild things. Patients with a hypomanic episode are more likely to be able to keep functioning and go to work. They just lose their need for sleep and feel more hyperactive compared to normal. These patients tend to have an inflated self-esteem, but they don't have the delusions of grandeur, feeling like they can do anything in the world. Their thought tends to be more organized, they have more energy, but it leads to more productive activity. So for example, some patients who have hypomanic episodes will get lots of work done because they're not sleeping and they're sitting at their computer and they're doing all sorts of things. It's productive. This is in contrast to mania, where patients will go out and spend all their money and gamble and go out to bars drinking. Those patients aren't doing anything productive. And then finally, there's milder risk-taking behavior. So this is a milder version of mania. Patients don't do as much disinhibited and irresponsible things. Hypomanic episodes last at least 4 days and they resolve over a few weeks, and they can never have psychotic symptoms. So we'll talk later about how severe versions of depression and mania can lead to psychotic symptoms. If you have psychotic symptoms, by definition, you have a manic episode, not a hypomanic episode. So a typical case is a patient who has a change in mood to elevated state but continues social functioning and resolves in a few weeks. And as I said before, they will often report that they are able to get lots of work done. Patients who have a manic or hypomanic episode have some form of bipolar disorder, which is also called manic depression. And it gets this name because many patients with bipolar disorder have mania and depression. And as I told you before, mania and depression are at opposite ends or poles of a spectrum. That's why it's called bipolar disorder. Bipolar disorder can present with mania, hypomania, or depression, and this is important to remember. When a patient shows up with depression, especially if you see them on your psychiatry rotation, you have to ask them very carefully if they've ever had mania. If they have, then they have bipolar disorder. If they have isolated depression, then they have major depressive disorder. And the reason this is important is because there is some evidence that if you treat patients with bipolar disorder with antidepressants, thinking that they just have major depressive disorder, that may potentially cause mania. Now, this has been called into question in recent years, how likely antidepressants are to cause mania, but nevertheless, it's important clinically to distinguish isolated major depressive disorder from depression that occurs in the context of a person with bipolar disorder. We say that patients have bipolar disorder 1 if they have a manic episode plus or minus depression plus or minus hypomanic episodes. Any manic episode equals bipolar 1. That's the easy way to remember it. We say that patients have bipolar 2 disorder if they have hypomania and depression but no evidence of manic episodes. The typical course for a patient with bipolar disorder is mood fluctuation. These patients will go back and forth over months or years through episodes of mania and possibly hypomania and depression. In between episodes, they may have periods where they have what's known as euthymia, which means a normal mood. So for example, if we draw a line and say that this line represents euthymia and anything above the line represents mania and anything below the line represents depression, then a person with bipolar disorder may go through a course like this over a few months or years. They may have an episode of mania followed by a period of euthymia and then an episode of depression and then sometimes later an episode of mania. This is what bipolar disorder looks like. In contrast, patients with hypomania have lesser manic episodes, and patients with major depressive disorder have only depressive episodes with no mania. The treatment for bipolar disorder is often with drugs called mood stabilizers. Most of these drugs are also anticonvulsants that can be used to treat seizures. One of the classic drugs used in bipolar disorder is valproic acid. Other drugs are carbamazepine and lamotrigine. And I talk about all three of these drugs and their mechanisms and side effects in the neurology section in the video on seizures. Another drug that can be used is lithium, which I talk about in another video. Antipsychotics are sometimes used. And then finally, as I mentioned earlier, it's classically taught that antidepressants may cause mania in patients who have bipolar disorder, although as I also mentioned earlier, this has been called into question in recent years. Some patients with mood disorders develop psychosis or psychotic features. Often this is hallucinations or delusions. These occur in severe forms of mood disorder, and the word severe is important. This can happen in depression or bipolar disorder, but it's going to happen to someone who is very, very unwell. So for example, a patient with a major depressive episode and suicidality, that patient may develop psychotic features. A patient with a major manic episode that doesn't sleep for many days and has lots of symptoms, that's the type of patient who may develop psychotic features. Importantly, a mood disorder with psychotic features has psychosis only together with mood symptoms. In other words, the patient never has hallucinations or delusions in absence of symptoms of mania or depression. If the patient sometimes has psychosis without mood symptoms, then that patient probably has a schizoaffective disorder, which I talk about in the video on psychotic disorders. So major depressive disorder and bipolar disorder are the major mood disorders, but now I'll go through some other mood disorders. The first one is called cyclothymia or cyclothymic disorder. These patients have mild mania symptoms and mild depressive symptoms, and they do not meet criteria for hypomania or major depressive disorder. Symptoms have to come and go over at least 2 years to meet the DSM-5 criteria for cyclothymic disorder. So these patients will have symptoms that come and go with ups and downs. They occur at least half the time, and they are never absent for more than 2 consecutive months. If all of these criteria are met over the course of at least 2 years, then that patient has cyclothymic disorder. Basically a very mild form of mood disorder. Persistent depressive disorder, which is also sometimes called dysthymic disorder, is a low-grade form of depression. It's less severe than major depressive disorder, but more chronic. As I told you earlier, patients with major depressive disorder tend to have episodes. They'll be euthymic and then get depressed, and then be euthymic and then get depressed. Patients with persistent depressive disorder tend to be mildly depressed, but for longer periods of time. To meet criteria for this disorder, the patient has to have a depressed mood most of the time for at least 2 years and no symptom-free period lasting greater than 2 months. The major distinction between this and major depressive disorder is that the symptoms are less severe but longer lasting. Let's talk about suicide. Unfortunately, suicide does occur in patients with depression and bipolar disorder. 95% of successful attempts have a psychiatric diagnosis. This is often depression or bipolar disorder. It also often occurs among patients who have substance abuse, and it's also common in patients with schizophrenia. In general, women tend to attempt suicide more often but are less often successful. Men have fewer attempts, but when they do try to commit suicide, they are more often successful. It's high yield to know that the most common method of a successful suicide attempt is use of a firearm, and any patient with a mood disorder who has access to guns is at increased risk, obviously. There is a risk scale you can calculate for a person to determine their suicide risk. It's called the SAD person scale. It gives a patient up to 10 points depending on which of these features they have present, and these are often remembered by the mnemonic SAD person. So the first S is for sex. Men are more likely to commit suicide successfully, as I just told you. Age is a risk factor. Young adults and the elderly are more at risk compared to middle-aged patients. Depression is a risk factor. Anyone who's attempted suicide before is in a higher risk group. Anyone who uses substances like ethanol or drugs is in a higher risk group. Patients who have loss of rational thinking, meaning they're psychotic, as I told you before, psychosis is seen in severe mood disorder. So anyone who's got psychosis, by definition, has a severe mood disorder and therefore is at higher risk of suicide. If patients have a concomitant medical illness, which is sickness, that puts them at higher risk. If patients have an organized plan, they're at higher risk, so this will come up on your psychiatric rotations. Your attendings will want you to ask the patient, have they ever thought of suicide? And if they say yes, they'll say, do you have a plan for how you would do it? If the patient says, I have no plan, I have no idea how I'll do it, that patient is at lower risk. If the patient says, yes, I think I would do it with a gun, and there's a gun in my house, and I know how I would use it, that patient is at higher risk because they have an organized plan. Patients who do not have a spouse or lack social support are at higher risk. And then finally, patients who have stated intent are obviously at high risk. If a patient says, I want to kill myself and I'm going to do it, that patient is in a high risk group. Now let's talk about grief. Grief is the emotional response to the loss of a loved one, for example, a husband or a wife. And acute grief is the grief that occurs just after the person dies, and this is a normal response. It classically goes through 5 stages that were defined by Kubler and Ross many years ago. The first stage after the person dies is denial. So, for example, if a wife has lost her husband, she'll say to the doctor, he can't be gone, there must be a mistake. The second phase is anger. So in this stage, the wife might say to the doctor, this is your fault, you did something wrong. The third phase is bargaining. Patients will often bargain with God or the universe. They'll say, I'll do anything if she or he could be alive again. The fourth stage is depression, where the patient is simply sad over the loss. And then the last phase is acceptance, where patients accept that the loved one is gone. Now, during acute grief, it can be normal for patients to experience visions or voices of the dead person. This does not necessarily indicate psychosis. And then lastly, acute grief is defined by the fact that it resolves within 6 months. Grief that lasts longer than 6 months is called persistent grief. This will interfere with the patient's social functioning. They may have difficulty going back to work after the loss of a loved one, and in many cases this leads to major depressive disorder. So the high yield thing to remember is that acute grief always lasts less than 6 months, and when you're on your psychiatric rotations, this is what your attendings are going to ask you. If you see a patient who is grieving, they will say, what is normal grief? And the answer you want to give them is it lasts less than 6 months. Longer than 6 months indicates persistent grief and a risk of progression to major depressive disorder. Let's talk about postpartum mood disorders. These are mood disorders that occur among women after their baby is born. The first one is postpartum blues. This is very common. It occurs in up to 85% of women in some studies. Many women, a few days after their baby is born, will find that they have a depressed mood. They can have insomnia, they may be fatigued, and they can have poor concentration. And this is called the postpartum blues. The symptoms tend to be mild. They start a few days after the baby is born. And importantly, they resolve within 2 weeks. This is what you want to remember for your board exams. Postpartum blues always resolves within 2 weeks. And it's important to identify this because the treatment is simply supportive. The symptoms go away on their own. Second disorder is postpartum depression. This is less common, but in some studies it occurs in about 15% of women. And the definition of postpartum depression is symptoms that persist after 2 weeks. So once again, that 2-week time frame is what you want to focus on when trying to figure out whether a woman has postpartum blues or postpartum depression. And in contrast to the blues, depression is treated with cognitive behavioral therapy or medications. And then the last postpartum mood disorder is postpartum psychosis. This is very rare. It usually occurs among women who had a psychiatric condition at the time they became pregnant, and I talk about postpartum psychosis in the video on psychotic disorders. I've listed some of the treatments of mood disorders. I've touched on some of these earlier in this video. The first one is cognitive behavioral therapy. This is basically talk therapy with a psychotherapist to help the patient understand and manage their emotions. Second one is antidepressants, which I talk about in a separate video. I mentioned mood stabilizers earlier, like lithium and valproic acid. And then the last one is electroconvulsive therapy. So ECT, or electroconvulsive therapy, is called by some people the shake and bake treatment. The patient is placed under general anesthesia and electricity is administered to the brain via electrodes, as shown in this picture here, and the idea is to induce a seizure under controlled circumstances. This is generally only used in refractory depression, and it actually works. Patients will go to sleep from anesthesia, they will have a seizure under anesthesia, and when they wake up they feel much, much better. It's amazing if you ever get to see this done. The main side effect of this that you need to know about for your boards is amnesia. Many patients, after they wake up, will forget things for several weeks later. Sometimes they have retrograde amnesia, where they can't remember things from before the procedure. I met one patient who had had this procedure several times, but she did not remember it any of the previous times. Some patients will also have antegrade amnesia, where they lose memories for a few weeks afterwards. And besides the fact that this is used in refractory depression, you should also know that it's sometimes used in pregnancy. That's because women who are pregnant or who have just delivered a baby and have severe symptoms can have this treatment without exposing the baby to drugs. And that concludes our video on mood disorders.